Uzo on a project to make query and clinical operations data more actionable. Thank you all so much, the three of you, for joining and sharing your expertise and what you've learned both from this recent project as well as your successful careers. To the attendees, please send your questions in the Q&A and we will take them at the end. So to get started, please introduce yourself and tell us a bit about your role and why nursing documentation and workflow efficiencies are important to you and your organization. So Nora, we'll start with you.
Thank you, Gabrielle, and thank you to our guests. My name is Nora Lissi. I am a nurse by background. I did most of my career in the emergency room, and then I got into nursing management and staffing office and trying to manage staffing and quality and working with the various units. And I got very, I'm a nurse by background, very passionate about my patients, but then I kind of got old and had to get into something that would save my legs. And I took that passion to my nursing experience and working with finance, and I became the liaison for clinical operations, not just the nursing folks, but clinical operations and financial folks, and eventually IT folks to help them understand really what the operational caregivers need. Because it's my opinion, I've been working now with Dimensional Insight for 13 years, and still in these 13 years, I have been trying to drive the whole piece that, yeah, we have technology out there for, we have an EMR, that's great. Yes, it's been pushed, but it's only my opinion, and it's, take it as it is, a humble opinion, but I don't feel we're any safer. And I certainly don't feel that we've made it easier for the operational people to see what's going on with their patients in a quick fashion. I'm going to date myself. Back in the days when I was in nursing school, we had what we called a nursing cardex, and you probably all have learned about it as well. But that basically gave us, we can come into work, even in my clinicals. The night before, I had to go to the hospital, find out who my patient was, and then I'd go look at their cardex, get their history, and you could quickly see what's going on with the patient. In a quick synopsis, it's not everything, but it's there to give you a history. So you're not spending an hour on every patient to look through an EMR, to click through notes, click through labs, click through doctor. And so my passion has come out with that. So I worked with Colby Lutz, who is he's an IT person at one of our facilities that we work with, and I'll let him introduce himself. But he actually has a passion for our tool and for what I want, and he works directly with clinical folks. So we teamed up together with Ephraim McDowell in Kentucky because they expressed some of the same issues we had, and I said, well, let's partner together and do something. So they are a Meditech customer, and we brought in all of their nursing and documentation queries, not just nursing, orders, radiology, all the different departments, brought them all in so that when the caregivers need some assistance, they can actually go, where is this field? And when they're asking for their request, they know exactly what data they're looking for, what field it's coming from, and what they need to tell IT. So it's a lot easier to put together and actually work through that and see what their numbers are. We use this information to enhance your hourly census. So that's my passion. I won't get any further into what we've done. I just want to explain what we did here so that we're trying to make it more easy for the folks that are at the bedside doing the work to be able to quickly look up a patient and find out what's going on and know in a quick hurry and not have to go through multiple pages. I'll send it off to Colby now and he can introduce himself.
Hello, everybody. My name is Colby Lutz. I've been in healthcare IT data analytics for 13 years. My background is a software engineer out of college. I have my master's for that. So the clinical aspect is something that I've learned more or less on the fly, working with hospital data. I've worked with basically every department in the hospital, from radiology to oncology to nursing to care management to discharge planning, finance, all across the board. So I've got kind of a vast view of what it do help improve outcomes across the board for each individual service line. But a lot of where I feel like the most impact has been made is directly with the nursing documentation, streamlining that so nurses aren't spending so much time documenting or duplicate documenting in different locations, also making that data more accessible for folks to help create their patient lists, to help drive the clinicians and the transitionists and your planners to have a bigger impact on their time with these folks. So using Dimensional Insights tool and other tools throughout my career, my goal has always been to get the right data to the right person at the right time. That's always the most important step to make sure that you have the biggest impact, or else you're wasting valuable time. That people could be at the patient bedside. So Nora's that I had and the tool that's available, and we came up with a uh, pretty good system for getting almost real-time data into the hands of these folks, these caregivers that are at the bedside, to kind of help prompt them to have the conversations that you would have during nurse handoffs or during shift change or anything, but to have that data available pretty much 24/7, accessible within a matter of clicks. Uh, the EMR, which the goal to have it outside the EMR is simply because you all know when you're in an EMR, there's different modules, there's different places you have to go to look for different documentation. If we can centralize all of that for you in a Cardex, in a digital Cardex is what Nora has deemed it, it keeps you on the go. It keeps you moving. It helps, like I said, it helps kind of template those conversations to help you be more productive in everything that you're working towards. So that's been a lot of my passion is driving the outcomes for the patients, helping improve everything from length of stay, readmissions, costs, but also helping the nurses themselves be more productive in the sense of not having to do extra documentation if we know that we could pull it all together for them in one place, keeping them, trying to not let them get overwhelmed as much when it comes to the documentation in the EMR. And I'll pass it over to Brandy.
Hello, everyone. My name is Brandy Buzo, and I'm the Quality Improvement Coordinator at Ephraim McDowell Health. I do our entire system. So we have a medical center and then two small critical access hospitals. So when Nora and Colby originally came to me, I didn't know what Dimensional Insights was. I didn't know what we were going to get from it or expect from it. But in my role, I'm always looking for better tools because there's a ton of data out there, but if it's not the right kind of data or it's not accessible data, then it's not meaningful or useful for anyone. And so I can get my fingers on tons of numbers and information, but it's not actionable. It's not real time. And so I hear a lot of complaints all the time from our frontline staff who, and I was there, I was an ICU nurse, complain about needing to be able to access information in a much more efficient way. And it's hard. EMRs have helped a lot. We have a lot more information available to us from other areas, especially. But if it takes me 20 minutes to dig through a chart and find something, then that's 20 minutes that I'm not able to be doing something with that information. So there's a lot of difficulties out there for frontline staff and for managers and for quality and trying to pull all of those pieces together. And so I became very passionate about it very quickly. When I first started, I didn't know what to ask for because I didn't know what was available, but Nora and Colby can tell you that I very quickly was like, oh, can we do this? Can we do that? Can we do this? So it's been a huge, huge help to our organization. And I've become very passionate about finding better ways for all of our associates at the hospital. So.
Thank you all so much for those introductions. I'm really excited to dig into our conversation today. So to get started, nursing staff members obviously spend a really significant amount of time documenting patient care activities in the EMRs, whether that's during their shift or even, staying after their shift to get it done. So my question is, what benefit are nurses and the rest of the organization getting from the information that's embedded in that documentation? And what are the barriers to actually accessing and analyzing that data?
I would say a lot of what the barriers are is just that everything is being documented in different places. Whereas you need a holistic view of what the patient is going through, whether that be lab tests, whether that be the administration of different medications, the timing of those administrations, the timing of the orders for the physicians when they're putting things in. A lot of times that's not centralized right in front of the nurse at their fingertips. So even during handoffs or when they're walking into a patient room, or if, the call light is on and you're running from room to room, it's taking a lot of your time, a lot of your energy to bounce back and forth and make sure that you have everything you need to be able to breathe. So the fact that you're documenting in multiple places, whether that's to populate, different reports in different places, you tend to over document before you know, can take care of the patient the way that you should. And that's a lot of, and I'm speaking on this all from the IT side. So I don't have the luxury or the pleasure to have worked at the patient bedside, but I can see that in the data. I can see where you're asking the same question multiple times, different ways, because you're at service line or something. And that's all things that I approach as opportunities, right? If we can document it in one place where the expert of that documentation does it versus a nurse that, might just be clicking down through to make sure that they've hit all the fields that are available to them, you're going to get more accurate information, and therefore you should be able to take care of the patient a little bit better. You're going to get a little bit more of your time back.
I would agree. That's a great segue, Kobe, when you talk about that. One of the things that Brandy had mentioned early on when we started even doing looking at the queries and where the nurses are documenting in the different places, that was one of the first things she tried to tackle was, okay, we have so many times we're repeating our documentation. If I can go back to my staff and say, you no longer have to document this because PT is already doing it and it flows into our stuff, so we don't have to do it twice, then that's already taking work off their plate. And so some of the other barrier is the fact that physicians will document in their module, nursing staff documents in their module, respiratory does it in theirs, PT does it in theirs. In the end, by the end of the day, you can all look at it, but you have to be going click in different places. And so, a nurse who's really intent on understanding what's going on with the patient and wants to start her shift knowing what's going on, you got 5 or 6 patients, that could take you quite a long time just to prepare to get your shift, or even to help providing report. We often forget what half the stuff we want to tell our co-workers because we just worked 12 hours. It's been a busy day and we want to go home. So when you have these, when we can pull the data together for you and show what tests were performed today, what tests are pending, what are they doing here, what are they doing, and you just print this off and you can give report, you're not missing anything. You can say, I gave them Demerol, not Demerol, I gave them pain meds 2 hours ago, and they're not due again until 6 o'clock, or this, that. It's all right there for them while they're giving reports. So it makes their life much easier, and it will make, I firmly believe that it also will help to close some of those Swiss cheese holes that line up if you forget one thing. So I find that as some of the advantages and disadvantages, if you will.
I'll just add on to what Nora said. And I know that at our organization specifically, duplicative documentation is massive problem. We have an older version of Meditech and it has been pieced together, and we've needed this change, we've needed that change over the years, and we add in a new intervention because, oh, now we have to report this to CMS and now we have to do this. And so we add in all of these things, but we've not been very good at looking and saying, okay, well, if we're adding this in, we can take this away. And so it's just piled up and piled up and piled up. And one of the most common complaints we hear from our nurses, especially nurses who come from outside organizations or who are travelers or have used other EMRs, is, oh my gosh, it takes so long to document because there's a million places. And so if it takes that long to document it, imagine how long it takes to try to look it up and to find what you need, because you're putting so many things in so many different places. And so, we have started really focusing at our organization on trying to tackle some of those burdens and those barriers that occur, because still to this day, nationwide, like 50% of all healthcare errors comes from errors or omissions in communication. And that's between nurses, that's between nurses and doctors, that's between nurses and lab, that's between, radiology, whoever. And part of that is, we just said omissions, right? If I have to go and look 15 different places to try to think of everything I need to tell you, then I'm gonna forget something. It's human nature. It's common. It's just going to happen. And so being able to know these are hot topic items that I'm almost always going to have to look at on every single patient and pulling those into one place, that takes a huge step towards that, right? I can look at this one page and I know these are my hot topic items. Yeah, there might be this random event on this one patient that I have to tell you, but now I just have to remember that one random event because I've got everything else in one place already ready for me to go. Without having to go dig for it. So it takes up a little less brain capacity of having to get ready for that handoff or that report. And it's not just nurse to nurse. It could be nurse to doctor. It could be nurse to anybody. It gives you that quick snapshot of your patient. And, you know, Nora talks about a long time ago, you had your Cardex, right? And even me, I just was in the ICU. I think I left the ICU 5-6 years ago. So even then I had my sheet of paper and I would come in and I would write down all the things and I would want to have this, and this on my patient. And this takes that step away. So it gives you more time to be able to actually take care of the patient, which is huge for the nurses. But I think documentation is wonderful, but it is also such a burden because you've got to have it, right? You've got to document. If you didn't document it, you didn't do it, right? Like all the nurses know that. If you didn't document it, you didn't do it. But at the same time, you've got to have the time to do it. You've got to have the time to take care of the patients. So anything we can do to streamline that report giving, that documentation, that finding information in the EMR gives you more time as a nurse to be able to be a nurse.
And so some of this documentation that we're talking about is, say, for instance, you know, something as simple as everybody's supposed to be monitored for sepsis, right? It's the #1 kill in the ICU. So are we completing, is every patient getting at least an initial sepsis assessment? Are we doing daily weights on our CHF patients? As Brandy said, if it's not documented, you didn't do it. Well, if it's not documented or it's documented on paper, but it never makes it to the record, then we're having a problem there too. So we're pulling in. So when we say we're creating data, we're pulling in data that'll allow the nurse managers / charge nurses to be able to say, hey, you know, we got this patient that's been sitting here for 3 days. They haven't been seen by PT yet. And there was an order for PT 2 days ago, or things like that, so that it kind of gives you a work list rather than having to remember. We can't remember anything anymore. We're all old. At least I am. And, you know, so it's like you have to write things down. Well, sometimes you write things down and you can't get them, but you pull this sheet out that says, here's what's been going on. This was the order. It was done, or it's not done. It's in transition. So you can take action and you could do something to make sure you're taking care of your patients in the best way. And it also will provide the ability when you find you have pain points, like you can't even, this is not something that is actually, you can make generic, but there still is all specificity to the pain points at which the organization has, right? So this, or even the floor, maybe this unit is the one we seem to have a lot of falls. What's going on? What can we pull to find out why we're having this happen on this unit? So help grab data for root cause analyses, pulling information in and not waiting till you get the report 6 months later from NDNQI or Premier or somebody that says that you're not doing that great. You can kind of feel it. If we're pulling that data in and we're giving you the examples, now you know what you're doing and you can make changes before it becomes a harm. And so that's the whole purpose behind this, is trying to give the caregivers what they need to prevent harm in the patient. That being also, when we talk about Brandy, you know, a lot of hospitals have gone to where, you know, we specialize and we'll say, okay, we have a heart failure nurse navigator, we have a diabetes nurse navigator, but those nurse navigators, #1, are supposed to know everybody in the hospital that they're responsible for. How do they know that? They have to sit down at a medical record and go, oh. No, they don't now. We've done one of two things. #1, we've created a list of those that are known heart failures or known diabetics. But then you also build that AI algorithm that says, you know, this person has a BNP over 900. They've had these studies done. They've had this done. They're on the 5th floor. They're not on cardiac, but everything they haven't done kind of points towards potential CHF. That goes on the heart failure nurse navigator's list. She or he then goes and says, okay, they're not. They're doing something else. They just happen to be doing similar tests. Or they go, this is a heart failure patient. We probably need to make sure that they get this, and this done and send them to that floor. So it allows a lot of that movement too, to kind of see where you're going from a caregiving standpoint. So each one of those work queues can be created for each different type of navigator or issue you have.
Thank you so much. Oh, sorry. Go ahead, Brandy.
I know, I was gonna say it's huge, because when you're depending on just consults, for a nurse navigator, or you're depending on them to just weed through all the patients that have been admitted, they're spending way more time having to find the patients than they are taking care of those patients and getting out there and getting them educated and doing the things to do to make sure they're getting the proper treatment. So, it's huge.
Yeah, there are some really good tidbits in that discussion. The things that really stood out to me are, the fact that we're talking about the efficiencies, but it has very real impacts on the quality of patient care. And Brandy, your point about, how often errors are due to communication. And then the other thing I want to drill down on is kind of this idea of like freeing up the mental space for nurses to actually focus on caring for patients and communicating better. And instead of trying to just pull things from a million different places. So when we think about challenges that nurses face today, another theme that comes up a lot in the research are interruptions. So regardless of care setting or service line, nurses are constantly being interrupted, whether they're providing direct patient care, they're documenting something, or, any of the million other tasks on their plate. So I'm wondering if any of you see a role for this streamlined documentation and data approach and access to that relevant data, and the work lists as a way to help reduce interruptions during a nurse's shift and what that might look like.
Well, I can go first with that one. So I think that the first thing I would say is the less time I have to spend at the computer documenting, the less opportunity there is for me to be interrupted during that, right? So if I have to sit at the computer for an hour to work on doing some documentation or finding information that I need or pulling it together or whatever, it makes me think of the beginning of my shift. I always sat down, I filled out my sheet, I wrote out my meds. That takes time, right? Then you have to go do all your assessments. And so if I'm spending an extensive amount of time trying to find information and get all the things that I need, then that's more time that I have to be interrupted during that process. And every time that I get interrupted during that process is an additional chance for an error. It's my mind has to shift to something else. And that's a time that I might forget to write something down. I forget where I was and I go back to a different spot and I've missed something in that process. So streamlining our information gives you less opportunity to be interrupted. And if I have things pulled together for me, then it's less I have to work on, and it gives, so you don't have to interrupt me during it because it's there for me, right? I'm not having to manually do that. So there's not even an opportunity at all during that to interrupt me. In addition, not just at the nursing bedside, but looking at the directors and looking at quality and all of those other pieces, being able to quickly access those information. So look at the nurse navigator, right? Her workflow completely can change when information is given to her. A director's workflow can completely change when I can get a snapshot overview of my department quickly and easily. That gives them more time to be able to give that feedback to nurses, to help nurses, to coordinate the staff and say, hey, we've got this, and this going on. We probably need to focus more staff here. We need to pull some more people here, things like that. And so the operational piece of it as well, just gives you more of an ability to be able to focus your energy and your time on the actual documenting, on the actual pulling of the information, and actually being able to take care of your patient.
Right, I agree. It's still one of the things that I feel is missing in healthcare. I always laugh because the operation, and I call it the clinical operational people, because it's nursing, it's everybody that's taking care of that patient, right? It's PT, radiology, everybody. They don't have any kind of work queues that say, you got to do this, you got to do that. Finance gets their stuff, IT gets their stuff, and each department has a an electronic tool that they can pull reports out of, but there's nothing that's providing a quick look, a quick work queue, a quick, these are the things you're missing, guys, and that's really what you need because, and again, I'm an old nurse and I know I had a lot of patients when I was an old nurse, but it's a lot different. And my patients were sick, but they're sick. These people are sick. You've got a lot more family members that are around the bedside that you're constantly having to answer questions for. If you can quickly pull out a piece of paper and go, yeah, that test was done yesterday at 10 o'clock. We're waiting on the results. It's that much easier for you than having to say, I don't know, let me find out. I'll go back to the doctor. Then you forget. Then that patient says, I asked that nurse 3 times for my results and she still isn't talking to me. It's all the overhead that caregivers have to put up with that nobody understands but the caregiver themselves. And that's why we're trying to make sure that we can do whatever we can to make life easier for the caregiver, because in the ultimate end, it's the patient that's going to benefit. And that's the bottom line of our passion, is those patients. How do they benefit? By providing the help to the people that provide the care. In case you couldn't feel that passion.
Nurses at heart,
I'm not
always.
sure there's much to add. To say, I'm not sure there's much to add on to that. They kind of got all of it, but again, it's just to reiterate, it's the right information to the right person. So if you can keep it off their mind that they need to go look up the most recent lab results, or maybe there was a lab testing that they didn't know about, but as they're walking to the patient room, they've got the printout where all that data is centralized, and they know, okay, well, it's just this part of the screen. It's not that I have to go through this menu and this menu and this menu and this menu to get there. It's almost like they can focus on something else on their way to the patient, bedside. So when they get to the patient bedside, they can do a full review, or they could do the handoffs maybe closer to the bedside instead of the nurse's station, where more folks are conversations, or they're getting passed by. It's more about just making sure that they have everything that they need at the right place at the right time.
Absolutely. And I think that segues nicely into talking a little bit about the technology. So something that came up earlier in our conversation is that there's a gap in EMR functionality with respect to patient care in supporting nurses in completing those patient care activities. So part of the issue is that EMR is, of course, designed to be a database versus those work lists. So I'd love to hear a little bit more about the functionality gap that you're experiencing with EMRs. And then when you think about adding new technology solutions, how do they assist with that gap? And what have you learned in implementing these new technologies to solve some of these problems?
So Brandy, why don't you start off with that, since we weren't working with you? I'm going to toss the ball over to you as she smiles and says, there you go, Nora.
I was gonna let Colby, he's the tech guy that's so smart.
Yeah, but talk about how much advantage you've gotten with what we've done for somebody who was not even technical, and now you've got something that's amazing, right?
I'm getting a little more technical, yes. So I would say that EMRs are wonderful, right? Like it was much needed. It's wonderful. We have access to information about patients that we never would have had access to before, right? Because you can pull in stuff from where they've been to the doctor's office, or they've been to another hospital and they've got these medications, and oh, they had this in their history. There's access to so much more information in an EMR, but just like you said, it's a database, right? It is a place that we input information and it can spit back out that information, but just that, right? It doesn't analyze it. It doesn't build on it. It just contains it. And so that is hard for quality people, right? Because I was constantly saying, well, I need to know this. And how can I get a report that will tell me that without sitting there and going into the chart and manually looking at 1,000 patients? And a lot of times they could try to build me a report from our EMR. We have a great IS team that will try their best, but there are limitations. There's only so much it can do. And so they would try. And then we have outside vendors who will give us data based on things we send to them. But, if I'm looking at readmissions or I'm looking at this or that, our costs, our ODEs. When I'm looking at all of those things, when it's coming from, say, Premier, outside organizations, it's delayed, right? It's coming back. I've had to close the chart. We've had to code it. We've had to bill it. We've had to send the files. They've had to process it. You're going to always have some delays with some things like readmissions because you're looking at 30 days. But I never was able to look at it real time. And I even asked, I'm like, is there a way that I can put a flag in Meditech that will tell me when this patient comes back? Because I can't get case management or my nurse navigator or whoever to go out and talk to this patient and try to figure out why is this patient back if I don't know that they're back. And so the technology to be able to do those things and do it more real time, I can now pull it up in that every morning. We can pull it up and see anybody who's been in our facility within the last 30 days. I can filter it if I want to, but I can also just see if they've been back. And so then people can go out and they can look at those patients and they can start trying to figure out why are these people back? Because then we can do something about it then, right? That 60 days down the road, I'm not going to be able to make any difference. It's too late. It's done. It's over with. And that's with any of our data. You look at our infection prevention data. We get the data. Yeah, we have it, but there's a lot of manual work that goes into knowing anything real time. Our IP are having to run reports from Meditech, then they're having to go into Meditech and look at the chart and say, is this accurate? And when did they do this? And pull this piece of documentation. And it takes forever. And it's not always accurate. And so EMRs, like you said, are EMRs. They are a medical record. They do not abstract. They do not analyze. They don't do any of those things. And so those outside computer programs help us to get the data, make it actionable, and be able to actually do something with it, right? We can make improvements because we still have the time to make those improvements. It's still real. It's still happening. It's then and there. It's not 6 months down the road, when I'm getting my CMS report next year saying, oh, well, that number was really not good. What are we going to do about it? Because now we're already into the numbers that are going to come out next year. So being able to get your hands on that information, I'm passionate about the quality piece because that's what I do. But the nurses, the nursing directors, a nursing director being able to look at her floor and say, hey, we've got 5 catheters that have been in for 4 days, 5 days. What's going on? Have we looked at these? Being able, and without her having to go and look at every single patient on her floor to see, and so there are benefits to outside programs that make the information you put in that EMR more accessible and more usable and more meaningful.
Yeah, to go on with that a little bit, it's kind of like coming from the IT perspective, the first question from a clinician is, I need to know what people meet this criteria. What person is a readmission, right? And in an EMR, you might be able to flag who a readmission is, but that's never the end of the questioning if they're really trying to dig down into the data, right? So we're trying to get to the different layers and trying to get to the different levels of what people want. And if you want to know about a readmission, you want to know, are they here for the same thing as they were last time? How long has it been since they were discharged previously? Were they able to meet with their primary care provider in between when they were discharged and when they came back? What other social determinants might cause this patient to be a readmission? It's never just as simple as let's just flag a readmission within the EMR. And medical records themselves are great for what they are. They're medical records, but trying to use a medical record for reporting or this time analysis where you're pulling in 20 different data points from 20 different places in the EMR, that's not what they're best at. So it's best to leave that to a tool that is good at that sits on top and can navigate those roadblocks that you would otherwise see within the constraints of what an EMR will do. And we'll talk a lot about Meditech and its limitations here today, but that's not strictly to Meditech. I've experienced that in Epic. I've experienced that in Cerner. I've dealt with a lot of EMRs, and everybody's having the same issues. You're all asking the same questions, and it's the right thing to do when you're push quality. And like Brandy was saying, is when you're trying to change quality outcomes, you don't want to wait 30 days to get these responses. You want to have them right now. So we're talking about catheters on a floor. Your first question is, who has a catheter? Okay. Next question is, how many of those catheters have been in for X number of hours and will need changed or are out of compliance for what our change requirement is. Okay, well, then we create work lists that we can automate pushing those out to those folks on those floors and say, okay, these need changed. Well, then what's the next step beyond that? It's, okay, well, how often are we in compliance? Now we're moving from here's your work list to here's your metric. Here's your measure that you need to track over time to prove that you're doing better, right? And then you want to know, okay, well, why is fifth floor doing so much better than third floor? Okay, let's use some of those best practices across the board. Now, can we identify those best practices by data, or do we just need to have a conversation with the management or the folks on the floor that are doing these things? But that's where the EMR isn't going to get you your answer right away, right? You can go in and analyze the data all day, one at a time, but how valuable is your time if you're a clinician or if you have that type of background that to understand all that information, but you're spending it reading through the chart of one patient at a time versus having this all roll up to the right place at the right time. So that's where, from an IT perspective, I'm trying to find out what's the root of your question. I'm going to ask you why or where 2 or 3 different times till I understand what your true need is, what your true ask is, so that I'm not building the first thing you ask and then you say, oh, that's great, but I need this. But I meant to ask you this, or now I need this, right? Let's try and get it, a good swing on the first try. So, identifying all that information from the start and identifying the limitations, or here's the 5 different criteria that would make this patient a higher priority for me to go see before this patient. And then we can weight patient lists that way. All that we have the ability to do. And then what we've built within this system is to make that more real time, right? We can make that real time for not just the nurses, but for your care management staff, your discharge planners, anybody else, your transitionists, or your anybody dealing with patients at the bedside. The idea is let those folks be what they're best at, right? If they're nurses at heart and they have that passion, let's not have them overanalyze the data. Let's present them with something quick that they can understand and they can get there and see more patients, because we really don't want to pay them to analyze the data, so pay them to be efficient at keeping these patients from coming back and being readmissions, or making sure that we're identifying opportunities by speaking with these patients to help the social determinants that they might be lacking in, post discharge. So that's, from an IT perspective, that's how I try and approach my thought process when I'm communicating with the nurses, the quality folks, about what their needs are whenever it comes to a system like this.
Yep. And a great example of that was where I was actually a customer of the organization I'm with now, and we were trying to do things like that. We had a lot of local churches that were willing to go in and see patients and take them for their prescription, get their prescriptions for them, take them shopping, take them to their doctor's appointments, but nobody knows about it. And so our pastoral department had given us a list of, I'm talking about like over 100 churches that would, if a person lived in that congressional area, they would go and take care of them. So we actually added that to the census every day, the zip code that they had, so that then that would trigger an alert to pastoral care to go have a conversation with that patient and say, we understand you live in this area and you have this, and we have a church that's willing to take you. Would you like to speak with them? So we don't automatically give it to them. We would have that conversation with them. But that in itself just adds so many more things that you're doing for that patient to make sure that they don't come back. You're identifying areas of risk, and then you're taking the avenues that are available to them to help you do your job to make sure they don't come back. So there's a lot of different ways of going around that and seeing the different things, identifying issues, with duplicate orders and such and like that. So anyway, I'm really excited about it. I think what we're doing and what we look to do is to be able to give the operational people at the right time in the right place the information they need, so that they can actually focus on what they're doing and not on paperwork or things that are not important at the time.
Absolutely. A lot of other good points in there, Colby. I know, when we talk about designing applications, we always get to what are the questions that we're actually trying to answer, and then you build everything around that. It's, the same with creating these reports or figuring out these queries. And it's never the first question. There's always something deeper. And, I love some of the creative examples that Nora and Brandy shared about, how is this actually getting used, or have you seen similar, supplemental technologies used in the past? So we have talked about a lot of examples throughout this, but this is your chance to share a little bit more, maybe brag a little bit. I would love to hear a little bit more about your organization, anything else you've been able to do with nursing documentation information to improve workflows and patient care. And then maybe what have your biggest takeaways been, or what advice would you give to another person or organization, trying to tackle the similar process?
Well, I'll start with the advice part, and then Brandy can start with how it's helped her organization, and Kobe actually, because Kobe's done it at his organization. But the advice part is you have to involve the people you're trying to do the work for. Because, and I have been caught myself early on in my career when I got out of nursing and into management. I sat behind closed doors with a director and we came up with a staffing plan and then went out and told the charge nurses what they had to do. And they go, that's not going to work. What do you mean it's not going to work? The numbers, they all add up. Well, the floor didn't flow that way. So you have to understand their workflow in order to help them with their work. So it needs to be interdisciplinary. It needs to be open dialogue about what the issues are, and it needs to be everybody has a piece of it, because then they take ownership and then it works. Go ahead, Brandy, or Kobe, either one of you can talk about how it's helped your organization with what you're doing.
So talking about project, we've done a lot. We've done small little things, as simple as, our patient experience office, the staff that's in there. One of the girls was having to every single day run a report to find out everyone in our hospital who was a DNR, DNI, and then she had to go in and manually look up what is their mental status, because if they had the proper mental status, she was having to go and talk to them about certain things and this and that. And so it was a process every day that was very manual. And we very easily and very quickly made a report for her that pulled those two pieces of information together, without her having to go to manually into the chart to do it. And that just made her day every day faster. She could get that piece of it done more quickly and move on to the other things, right? And that department always has things that come up, right? Because they go to codes and they go to rapids and they go to code stroms and they go to all of these things. They have patients that are upset and they need to go talk to them. They are constantly being pulled away from their desks. We want to talk about interruptions. Those girls are going all the time to every department in this hospital. And so when you have things that you have to get done in addition to those emergent things that are going to come your way, being able to make that more streamlined and her be able to get that done quickly is big for them, because they are constantly being pulled a million different directions. And so that's just an easy example, right? And then you have the nursing Cardex, which is huge, big project, right? Pulling in all those different pieces and knowing what is important to the nurses there at the bedside. And I was a nurse, but it's been a few years since I was there at the bedside. Nora, it's been years since she was at the bedside.
Mm-hmm.
Things have changed. Things change every week in nursing. I joke all the time because I say nurses are some of the most stubborn people. We hate change. We don't want to do anything any different. We want to do everything the same, but our jobs change every day. So it's funny. I think it's hilarious because we're very resistant to change, but we're constantly learning. Things are constantly changing. There's new requirements. And so we don't know everything that they need right now. And every department is a little bit different. There are going to be things that are very important on an ortho spine department, or that are going to be very, very important on mother baby, right? That my ICU nurse is not going to care one bit about. So no, what Nora was saying about pulling in that staff is huge on being able to, you want to have your standard, right? You want to have your across the board, this applies to everybody, but then you want to personalize it to those areas because you've got to have buy-in. And anybody who's working in a hospital right now, I can guarantee you're talking about morale. I think every healthcare organization on the planet is talking about morale still to this day. COVID did a number on our hospitals and our staff in our hospitals. And we're still trying to recover from that. and not just morale, but practice, right? It was a time of almost like war, right? We were doing the bare minimum that we had to do to get by to take care of patients. And you've got nurses that graduated during that time. So that's what they know. And now you're trying to come back out of that and say, well, there's really a whole lot more we have to do and think about and take care of. We can't just live in that world anymore. We've got to start doing these other things again. And that's hard. And that there's a lot of learning curve there for a lot of nurses, I think. And so we've got to be able to have that interaction and pull those nurses in, because there's a lot of resistance and there's a lot of I don't have time for that, I don't want to do that, well, that's not, we've always done it this way. And you've really got to break those walls down, but you don't want to, you're still working to build up your morale. And I know that almost every hospital is probably still trying to build that morale up in their staff. And so finding ways that you can make their job a little bit easier helps with that. Because every time I go to a nurse or I go to a director's meeting and I'm like, okay, we have this new thing from CMS that we've got to find a way to do this. If I just go out there and tell them, okay, you guys have to document this like this, then I can guarantee you, every single nurse is going to walk away from that conversation and be like, well, she doesn't know. She doesn't know what it's like to be at the bedside. She doesn't know what it's like to do my job. I don't have time for that. And I understand them because I used to be there. I did it too. So we have to find a way to work with them, coming from the qualities aspect of it. Because yeah, they have to do it, but it doesn't mean it has to be done this way. It can be done lots of different ways. And if you get them involved in that process and their buy-in, then it makes everyone's job a little easier, because then they do it. And it also makes it easier for them to do it. So like the nursing cardex, it's about making their jobs a little bit easier in the grand scheme of things. Nurse navigators, I've went to Nora and Colby twice now about 2 different navigators and said, hey, look, I need help. I need help finding these patients. My nurse navigators can't help them if they can't find them. And we've developed ways for them to be able to get that patient list. And they're both seeing more patients, which is more patients that are getting the education they need, more patients that are getting follow-up phone calls, checking on them and saying, hey, how are you doing? You know, are you using your zone tool? Are we doing okay? Trying to help prevent them from coming back to the hospital. So those are just some examples of some things that we've done personally. And that's just the icing on the cake, I guess, because I already have a list. Like I texted Colby after a meeting the other day and said, hey, Colby, so do you think this is something we can do? So I'm constantly coming up with new things, and we have to, right? We have to keep finding ways to making it easier and better, because the demands are not getting any less.
And I can give a little bit of background on where the idea for a lot of this came from, where the implementation came from. It comes from people that have a passion. To women, 2 nurses are on the call with me today, but I've had a lot of great experience with some folks that are just way more intelligent than me and in different areas, that they have such a passion for what they do, that when you allow them to have a voice in what is happening with their department or how they're being tracked, or maybe we should look at things this way, because when you look at it this way, you're forgetting this, and this. So a lot of times when you get your direction from, I want to say the top, but when you get your direction from the top, they're looking at what's the bottom line financial, how is length of stay looking, how is this number looking. And then you get down to the department, they say, okay, well, what levers can you pull to have an impact on those, right? So if we're talking length of stay, and I've had some great experience with some of my pharmacy folks that I've worked directly with. It's like, okay, well, what types of medication reduce the amount of, the pain scale for the patient, which would then, once their pain is lower, they're able to get PT faster. And once they get PT faster, then they're able to get out of the hospital a little bit quicker. You can talk to those people what kind of impact they can have on that upper level measure. So whenever these facilities, these companies come to you with these measures and they say, yeah, we can show you your finances. Are you in the black? Are you in the red? How's your readmission? How's this? when you go to the department, you want them to be the expert. You want them to tell you what kind of impact they can have and how to measure that and how to track that. And without the access to this detail level data that sometimes is within nursing documentation, but I don't want to leave to just nurses. There's pharmacists. There's all types of folks where this nursing documentation lives outside of the abstract of the medical record itself. So when you talk about that, you're talking about what levers you could pull to impact those top line that the other the more executive folks would be taking a look at. And it's just incredible the amount of buy-in and the amount of impact you can make whenever you get those folks to flesh them out and bring them to fruition. And that's something that I started to do on my own in my past. It's then identifying opportunities from Nora. She kind of pushed it to the next level. She saw, okay, well, this is great that you run this daily. Why can't you do it hourly? And it was just a technical thing to overcome. It wasn't that it wasn't possible. And then she kind of showed me how to make it more approachable from somebody that doesn't have as much of a technical background. So whereas I before was doing a lot of hand coding things and everything was functional, it wasn't forward facing. And that's something that we've worked on a lot is to be able to give the folks that need this information access to what information is available. Like, yes, you know that you want this. Do you know where you document it? Great. We'll click this button and I'll put it into it'll be in the data set without you having to contact IT. So think about how much time you can save if you don't have to make all these phone calls to, your IT folks to start pulling this information for you. If you've got everything, one of the pieces of this product that we built in is access to every query within the Meditech system for ePHRM, right? So now Brandy has the ability to go in, look at every documentation that's available, see how many of them are duplicative, see how they're being answered, how many times they're being answered. And then if she wants one of those fields within her data set, with the click of one button, she can have that within her data set within an hour. And then that can be put onto dashboards, that can be added to work lists, that can be moved in any which direction whatsoever. So that's a little bit of the background of where the idea came from, how it was implemented, the questions that were asked, and then identifying that, yeah, I mean, length of stay is great, and we all want to impact length of stay, or we all.
Oh,
What's being documented is what being done, and then just
oh,
go ahead. I'm sorry.
no, we lost you for a second, but you can go ahead and pick up from where you left off. Lost you for a second, but
Okay. Yeah. So it's more or less just you'll have the most impact if you can have individuals with passion, give them a voice, and help them lead and drive you. And then a tool like this that can put all that information in front of them so that they can quickly incorporate that data within their workflows just makes you that much more valuable to department, to your organization, but will make your organization that much stronger when it comes to data quality and quality of patient care.
fantastic. Thank you. I loved the points in particular about, getting the right people in the room to talk about the requirements, the people with the passion, the people with the buy-in. And then Brandy, to your point from earlier in our conversation, if you're reducing duplicate documentation or making the process easier, even though like you said, the requirements are never going to decrease. Like with adding these efficiencies, how nice is it to go to someone and say, like, I actually have something you can take off your plate. And that probably makes it a lot easier to make some additional asks. It's like, okay, well, yeah, I have to do these two new things, but last week you took two things off my plate, so I can live with that. Okay. So if anyone has a question, please feel free to send it in the Q&A. I'll give it a few seconds to see if we get any, and if not, we can have maybe one more rapid fire question before we wrap up. Okay, no questions so far. So I have one final question about AI because I'd be remiss not to bring that up. So we'll just, keep this one a little bit snappy. But I was
There is
reading.
a question.
Oh, it just rolled in. Thank you so much. All right, we'll do that instead. Okay, so the question is, have you begun to see a quantifiable impact on nursing staff yet, including workflow efficiency as well as improved provider experience? So Colby, do you want to start on that one?
Kobe, oh, there you go.
Absolutely. So, from my perspective, it is kind of from my perspective, it is kind of giving back a lot of their time to them. So let's not my personal experience is not so much with bedside nurses as this new piece is an extension onto what was built previously. But when it comes to those transitionists, being able to provide them these patient lists in real time every hour and quantify, here's who you need to see first, or here's who meets most of your criteria that might not have these services, and here's the services to offer them. You're talking about giving these folks hours of their day back so that they're not having to analyze their own data. They're not having to go into the record and look at it. But I've been told it's more or less feedback from our performance improvement team, as well as those individuals, that we've saved them 10 to 20 hours a week from information that they had to go and fetch themselves, or was run from an EMR report that didn't pull all the pieces together, or just didn't have access to additional logic once you had those pieces together, right? You might have, okay, well, pull in their BNP and pull in whether or not they got a daily weight done, or whether these things happen. You can have more or less true or false questions, but how much logic can you add to that to say, okay, well, is that BNP above this value, and has this occurred, and how long have they been in the hospital, and what patients should you see first? It's most of the time the patients that have been there the longest, that haven't been seen yet, that have, are the most critical. Or maybe you don't want to go see your ICU patient right away because they're on an event you're not going to be able to have an appropriate amount of conversation to do anything about. So not just having a list printout that you don't have all the information for, it really just helps guide you to exactly who you need to see at what time. So I've had a lot of impact with nurses at that level, and then the communication piece that we've more or less developed more recently is there's a lot of positive feedback on it yet so far, but I haven't personally gotten any direct feedback. I think that'd be more for Brandy if she's been able to incorporate it.
So I don't have exact numbers or any quantifiable data that I can give you on exactly how much time it's reduced yet, because we're still very much in the process of trying to integrate this into our workflow and trying to improve how we're doing our communications and our handoffs. We're doing a system-wide reset on handoffs across the board. Between nurses and providers, nurse to nurse, nurse to other departments, nurse to transport, everyone. So I will have that better in the future. I don't have it yet because we are right in the midst of doing that big transition of changing that. But I can say that firsthand, I do know that I have two nurse navigators who report directly to me, and they have been using some of these formats for a while now. And I know especially my heart failure nurse navigator has given a lot of positive feedback and praise about how much easier it makes her ability to identify patients in the morning, and to know who she needs to go see and to prioritize who she needs to go see. So that is one that I know for a fact, that I can directly say it's been huge for her. But I can't speak quantifiably about overall nursing at this point.
I can speak to when I did it as a customer. I did it at one of my organizations I worked in at WakeMed Health and Hospitals, and primarily I worked originally with case management, and they struggled with, finding all the new Medicare patients that got admitted last night, looking at those that are risk for readmission, identifying the different areas. So they gave us criteria. We added it to their census and gave them all the information of all the new Medicare admits after 7 o'clock. They also had rules on, when to, a patient needed to be seen by case management every 72 hours. And, they didn't know if that was being done because they did their stuff in their documentation, but it didn't carry over to the EMR, yada, yada. And when we implemented it and gave them their tool and their process, for the first time, I had somebody tell me, oh my God, I can do the work without having IT being the problem. because they were able to identify what they had to do. They had their new patients. They didn't have to go looking through it. And it made a huge difference for them. Same thing happened when I was in a meeting with physicians, and we were able to I'm going to use the term, dive down into the data when he was questioning things. And I said, well, here's exactly what happened with that patient. And here's what time they came in. He's like, oh, wow, this is great. This is the first time I've ever gotten a conversation that I leave the room and I'm not mad, because it was getting information that they needed at the time. And so well, I've had that feedback in several instances at that organization of what we did there. So, yeah.
Fantastic. Thank you
Sorry,
all so
I
much.
know we're over time, but I will just say that is one thing I can verify for sure is that I know I'm sure other organizations are the same. RIS and IT, they are overwhelmed and overworked, and they have a million things on their queue list. And there have our ability to be able to get information on our own and faster without having to wait for them to be able to run a report has drastically increased our ability to access data.
Thank you so much. I think that's a perfect note to end on. And thank you all so much for answering that and for sharing all of your wisdom today. Audience members, our contact info is up on the screen right now and will also be emailed to you afterwards with the survey. I'm going to just real quick share a message from today's premier sponsor. That's us, Dimensional Insight. Excuse me. Did not escape the spring cold. So we at Dimensional Insight are proud to be longtime premier sponsors of New England HIMSS. I work on the healthcare applications team, where we use the Dimensional Insight Diver platform to build end-to-end decision support applications designed to solve a variety of analytics issues related to operations, workflow, outcomes analysis, population health, and more. The positive feedback from our customers on these applications and independent surveys has helped us win the coveted Best in Class award in business intelligence and analytics in healthcare an unprecedented 11 times. That success comes from deep domain expertise in healthcare, coupled with the technical capabilities combined into our repeatable methodology. So if you're trying to figure out how to move forward with analytics, we would love to talk with you. You can find us on the web at dimins.com, or you can just Google Dimensional Insight. Again, thank you so much for joining. Thank you so much, Nora, Colby, and Brandy. This was a fantastic conversation. And thank you, New England HIMSS, for hosting us.
Thank you, Gabrielle. Thank you, audience.
Thank you so much. And following today's webinar, you're going to receive a brief
Thank you,
survey,
everyone. I appreciate it.
as well as an email with information on how to claim your CHP HIMSS credit for attending. So thank you, everyone, again. Have a great rest of the day.
Thank you. Have a great day.
Thank you as well.